Assalamu alaikum. I hope you're all doing well, inshallah. So today is our third BCPS preparatory class, and the lecture is about endocrine and metabolic disorders, which will be delivered by Dr. Muhammad Ammar Zahid. Dr. Ammar is currently a PhD candidate at College of Pharmacy, Qatar University. In collaboration with Hamad General Hospital and Qatar Biobank, his research mainly focuses on discovering new strategies to slow down the progression of age-related diseases. Previously, he has done his Pharm.D and M.phil in pharmacology from Pakistan and has more than 6 years of experience in pharmacy practice, academia, and research. He is a board-certified pharmacotherapy specialist and ASHP certified in pharmacy informatics. Thank you so much for your time, Dr. Ammar. And just a quick reminder for our participants, if you have any questions, please type them in the chat box and we'll go through them at the end of the lecture. So Dr. Ammar, you may now please unmute yourself and yes, share your screen.
Thank you very much, Kanza, for introduction. Can you see my slides? I have shared my slides with you.
Doctor, we can't hear you still.
Can you hear me now? Kanza, can you hear me?
Yes, sir, you are audible.
Yeah, Kanza, I think all other participants can hear me.
I'm not sure. I can't hear you, doctor. Can you please try joining again?
Can anyone else confirm that they can hear me well?
Yes, I can hear you.
Kanza, आप अपना speaker देख लीजिए. I think there is some problem with your speaker. So we have limited time. Let's start. So the topic of today's presentation is endocrine and metabolic disorders. So first thing, I have no conflicts of interest to disclose. These are the learning objectives of today's presentation. We will try to identify a patient of endocrine and metabolic disorders based on diagnostic criteria, and we will look at different classification criteria of different endocrine and metabolic disorders laid down by different guidelines. We will see how we can classify different patients of diabetes or, for example, patients of thyroid disorders, because they are the main focus of today's presentation. We will review therapeutic agents used for the management of endocrine and metabolic disorders, and we will compare and contrast different treatment options, which one are good, which one are better than the others according to the recommendations. And we will try to select appropriate treatment options and ways to monitor the outcome of the treatment according to the established practice guidelines. And obviously, some of these diseases, they have long-term complications, for example, diabetes. So we will also briefly look at how we can manage the long-term complications of diabetes. So these are the topics of today's presentation. अगर आप जो है वर्कबुक्स को देखेंगे, आपके पास अगर वर्कबुक्स हैं तो उसमें बहुत ज़्यादा डिटेल्स हैं मौजूद हैं. इसके अलावा भी पॉलीसिस्टिक ओवरी सिंड्रोम है, पिट्यूटरी ग्लैंड के डिसऑर्डर्स हैं, बट वी विल नॉट go in detail because we have limited time. So we will only focus on thyroid disorders, hypo and hyperthyroidism, adrenal disorders, mainly on Cushing's disease. We will focus on diabetes mellitus, and in the end we will talk about obesity. So let's start from thyroid disorders. As you already know that thyroid gland releases T3 and T4, and thyroid gland is under the influence of pituitary. So pituitary controls the secretion of thyroid gland by secreting thyroid stimulating hormone. And pituitary is under the control of hypothalamus, while hypothalamus secretes thyrotropin releasing hormone. So TSH, or thyroid stimulating hormone, is also called thyrotropin. So hypothalamus controls the secretion of thyrotropin by releasing thyrotropin releasing hormone. So why I am telling you this? Because this is important during the diagnosis of hypo or hyperthyroid disorders, because there is a feedback between the T3, T4 levels and the secretions from the pituitary and hypothalamus. So for example, when T3 and T4 levels are elevated, there is a negative feedback and TSH levels are low. In the same way, when T3, T4 levels are decreased in hypothyroid disorders, TSH levels, they are increased because there is no negative feedback to reduce the levels of TSH. So this is very important to diagnose the patients of hypo or hyperthyroid disorders. So if we look at the pathophysiology of these disorders, so in hyperthyroidism, the most common hyperthyroid disorder is Graves' disease. It is an autoimmune disorder in which antibodies are produced in the body which stimulate thyrotropin receptors on thyroid gland. So as we already discussed, thyrotropin is thyroid stimulating hormone. So antibodies, they stimulate thyroid stimulating hormone receptor. So that's why thyroid gland secretes a lot of T3 and T4. So keep in mind that TSH levels, what would be the effect of on the TSH levels? That TSH levels would be low due to the feedback. So this secretion of T3 and T4 is not due to the increased level of TSH. This increased secretion of T3 and T4 is due to the stimulation of TSH receptors by autoantibodies. There are other hyperthyroid disorders as well. For example, there could be tumors in the pituitary gland, and pituitary gland is secreting a lot of thyroid stimulating hormone, and this thyroid stimulating hormone would act on thyroid gland, and thyroid gland would secrete a lot of T3 and T4. We will not discuss these TSH secreting pituitary tumors in detail. We will focus on Graves' disease mainly. There could be thyroid nodules as well, uh, toxic adenomas in the thyroid gland itself, which could be a cause of hyperthyroidism. There could be multinodular goiter of the thyroid. There could be inflammation of the thyroid gland, and increased levels of T3 and T4 could be drug induced. For example, certain drugs like amiodarone or thyroid replacement therapies, they can increase the secretion of thyroid gland. You can see on the right, hypothyroidism. The most common hypothyroid disorders is Hashimoto disease. This is also an autoimmune mediated disease in which autoantibodies are formed against thyroid gland. So we will discuss Hashimoto disease and the treatment of Hashimoto disease in detail. This hypothyroidism could be a result of surgery or ablative therapy. So in hyperthyroidism, when we try to treat hyperthyroid disorder or Graves' disease by surgery or ablative therapy, we are destroying or removing the thyroid gland. So once a thyroid gland is destroyed or removed, obviously thyroid secretions would be reduced. So it could be a cause of hypothyroid disorders. Iodine deficiency could be another cause. Pituitary insufficiency, for example, pituitary gland is not secreting enough of thyroid stimulating hormone. If thyroid stimulating hormone is not there, obviously thyroid stimulating hormone is the main cause of secretion of thyroid hormones from the thyroid gland. And hypothyroidism could also be drug induced. For example, lithium is notorious to cause hypothyroidism. If we look at the clinical presentation, you can see that hyperthyroidism and hypothyroidism, their signs and symptoms and clinical presentations are contrasting. So in hyperthyroidism, for example, everything is revved up. Thyroid gland is like a thermostat in the body. So if it is activated, everything would be revved up, metabolism would be increased. If metabolism is increased, there would be a lot of weight loss, there would be heat intolerance, the skin would be warm and moist, there would be growth of very thin and fine hair, the bowel movements would be increased, and in extreme cases, there could be palpitations and tachycardia in the patient. The patient would experience anxiety, nervousness, and insomnia, and this is very typical of hyperthyroidism or Graves' disease, which is bulging of the eyes, exophthalmos, and the size of the thyroid gland could also increase, which is called thyromegaly. So these are all clinical presentations of Graves' disease or hyperthyroid disorders. In contrast to this, in hypothyroidism, there is weight gain, there is cold intolerance, the skin would be cold or dry, there would be coarse hairs, bowel movements would be decreased, bradycardia would be there in extreme cases, depression, lethargy, fatigue, and preorbital puffiness could be present in the patient of Hashimoto disease. So you should be familiar with the clinical presentation of both disease, because when we try to address one disorder, the patient, the balance could go out and the patient could go to the other side. For example, if the patient is of hyperthyroidism and we are trying to treat hyperthyroid disorder, the patient could go in hypothyroidism. In the same way, when we are treating a patient of hypothyroidism, the patient could go towards hyperthyroidism, and we will discuss it in detail. We will also cover a lot of cases in this presentation. So be awake and try to answer these cases. I will tell you the answers and I will tell you the justifications as well. So this is a case of a patient. She has difficulty with sleep. So obviously she has insomnia, mainly with staying asleep. It takes her 20 minutes to fall asleep, but after 2 hours, she wakes up and cannot fall asleep. So she has a problem with sleeping. She has insomnia. She took diphenhydramine, which is over the counter for sleep, but didn't continue due to drowsiness in the morning. Obviously, diphenhydramine causes drowsiness in the morning. Her other medical problems include hypothyroidism. So she is a known patient of hypothyroidism. She is being treated for hypothyroidism. How she is treated for hypothyroidism? By levothyroxine, 125 microgram at bedtime. She has hypertension. She is taking medications for hypertension as well. She has chronic back pain. She is taking ibuprofen for that. She has major depressive disorder. She is taking citalopram for that. Which agent is most likely contributing to insomnia? So she has insomnia. She is taking some medications and she is taking certain medications. So which of these medications could cause insomnia? So think about that and see that this patient is being treated for hypothyroidism and she is taking something for hypothyroidism which could produce symptoms of hyperthyroidism in this patient. So insomnia, that is a symptom of hyperthyroidism. So most probably this insomnia in this patient is due to the levothyroxine. So this is the concept you need to know, that when we treat patients with hypothyroidism or hyperthyroidism, the balance could go out. So if we are treating this patient for hypothyroidism by levothyroxine, the patient could experience symptoms of hyperthyroidism, which is insomnia. So levothyroxine is the answer for this case. So let's move to the diagnosis, and diagnosis is based on T4 levels and thyroid stimulating hormone levels. So you can see here the normal values of T4, T3, and TSH. And in hyperthyroid disorders, you can see T4 and T3 are raised. And when T3 and T4 are raised, according to the feedback, TSH levels are reduced. And in hypothyroid disorders, T3 and T4 levels are reduced, and because there is no negative feedback, TSH levels would be raised. So this is the primary diagnostic criteria for hyperthyroid and hypothyroid disorders. But keep in mind that we are only talking about primary thyroid disease. That means that the problem is with the secretion of thyroid gland itself. There is no problem in the pituitary, because if there is a problem in the pituitary, there is a tumor in the pituitary or adenoma of the pituitary would release a lot of TSH, and the hypersecretion from the thyroid gland is due to the hypersecretion of the TSH. In that case, both T3, T4 levels and TSH levels would be raised. So that's why we have put an asterisk here. That means that we are only talking about primary thyroid disorder. This situation would only be present in primary thyroid disorders, in primary thyroid hyperthyroid, or in primary hypothyroid diseases. So what are the goals of treatment in hyperthyroid or hypothyroid disorders? We want to eliminate thyroid hormone if it is in excess, and we want to normalize if it is below the normal levels. We want to minimize or eliminate symptoms and long-term consequences. And we want to individualize the therapy based on the type and severity of disease, patient age and gender, existence of non-thyroid conditions. For example, the patient could have comorbidities. There could be there could be cardiovascular problems in the patient. So we have to individualize the therapy according to the patient, and we have to individualize according to the response to previous therapy. So we will try one therapy. If that fails, we can move to another one, and we can individualize based on the response to previous therapies. So what is the treatment for hyperthyroidism or hyperthyroid disorders? So the gold standard is ablative therapy by radioactive iodine. So this is the treatment of choice because remission by pharmacotherapy is low. So the first line treatment or the treatment of choice is ablative therapy by radioactive iodine. But keep in mind that pregnancy is an absolute contraindication to use radioactive iodine. So if the patient, you see, we discussed that we have to individualize the therapy based on patient age and gender and circumstances of the patient. So if the patient is, for example, pregnant, then obviously ablative therapy by radioactive iodine is not an option at all. This is contraindication. Surgery is also preferred if the size of the gland, obviously we are talking about thyroid gland. If the size of thyroid gland is large, more than 80 grams, then we can opt for surgery. There is severe ophthalmopathy or bulging of the eyes, so then surgery is an option. Lack of remission on anti-thyroid drug treatment. So we tried pharmacotherapy before, but we cannot achieve remission. So in that case, we can opt for surgery as well. If surgery is planned, we have to give pharmacotherapy as well. So ऐसा नहीं है कि आप सर्जरी अगर कर रहे हैं तो फार्माकोथेरेपी जो है वो यूज नहीं करेंगे. If surgery is planned, for example, you have to give methimazole until the patient is euthyroid. I mean, until the thyroid secretions are normalized. इसके अलावा आयोडाइड जो हैं वो ऐसे पेशेंट में दे रहे होते हैं which is going for preparation of surgery. Similarly, propranolol or beta blockers are added several weeks before surgery to maintain pulse rate less than 90 beats per minute. So pharmacotherapy is reserved for patients who are waiting for ablative therapy or surgery. We already discussed that the treatment of choice hai, that is ablative therapy. But if the patient is waiting for ablative therapy or waiting for surgery, so we can use pharmacotherapy to deplete stored hormones or to achieve euthyroid. If the patient is not a surgical or ablative candidate, or he refuses or she refuses to take to undergo ablative therapy or surgery, then obviously pharmacotherapy is an option. And if ablative therapy or surgery fails to normalize thyroid function, then pharmacotherapy is used as an adjunctive therapy. So which pharmacological agents we have? Pharmacological therapy is based on methimazole and propylthiouracil. Both of these drugs, they are equal in efficacy, but their adverse effect profile is very different. So for example, propylthiouracil that has severe hepatotoxicity. So we prefer methimazole. So methimazole is the drug of choice if we are considering pharmacological therapy. Both of these drugs, they take some time to produce maximum effects. So ऐसा नहीं है कि जैसे ही आप जो है वो start करेंगे effect जो होना शुरू हो जाएगा. It would take some time. It would take at least a month to produce maximum effects, because hormone जो है that is stored in the thyroid gland, and those stored levels of hormone they reduce slowly. So both of these drugs, they require tapering monthly. So you have to adjust dose on monthly basis, and you have to treat the patient for 1 to 2 years. We already discussed that propylthiouracil has a risk of serious hepatotoxicity. So we consider methimazole as a first line therapy, but there are some exceptions. For example, the safety of methimazole is not established in first trimester of pregnancy. So we can use propylthiouracil in the first trimester of pregnancy. If the patient is intolerant to methimazole, then we can use propylthiouracil. And in thyroid storm specifically, propylthiouracil is the drug of choice and not methimazole. So keep in mind that if we are considering pharmacological therapy, methimazole is preferred over propylthiouracil because of its safety profile, except for these three conditions. Iodides could also be added in treatment, and iodides, they block the thyroid hormone release and they decrease the size and vascularity of the gland. Obviously, if the patient is undergoing surgery and he is waiting for surgery, iodides help to reduce the levels of thyroid hormone, and they also help to decrease the size and vascularity of the gland, which is beneficial during surgery. Symptoms improvement after iodides takes 2 to 7 days, and hormone reduced for a few weeks. They are mostly used short-term use for 1 to 2 weeks, because there is no benefit of using them long-term. Hormone ultimately starts release from the thyroid gland. So in iodides, you can use, for example, Lugol solution or saturated solution of potassium iodide. These are used before the surgeries to reduce the size and vascularity. So they are used as an adjunctive therapy to prepare patients with grave disease for surgery. They are also used acutely to inhibit thyroid hormone released in severely thyrotoxic patients. And they are also used after radioactive iodine therapy, after ablative therapy, because after ablative therapy, for some time, the stored hormone in the thyroid gland that leaches from the thyroid gland, to inhibit that hormone, we can use iodides. Adrenergic blockers, specifically beta blockers, they are used for the symptomatic treatment. So it doesn't affect the levels of thyroid secretions, but they are used for symptomatic treatment. So for example, if the patient is having palpitations, anxiety, tremors, or heat tolerance, these are classical symptoms of hyperthyroidism, then you can add a beta blocker, for example, propranolol and metoprolol, specifically in patients who are elderly and who are symptomatic, and the patient heart rate is more than 90, and there is history of cardiovascular disease, then there is a recommendation to add beta blocker. So in these three cases, when the patient is elderly and symptomatic, heart rate is more than 90, and there is a history of cardiovascular disease, according to the recommendations, you should add a beta blocker. So here comes the second case, 84 years old woman, so quite old. She complains of feeling anxious and warm. Anxiety and warm are typical symptoms of hyperthyroidism. She refused to undergo ablative therapy. Obviously, ablative therapy is the treatment of choice, but she has refused to undergo. TSH levels are 0.22, that's low. T4 levels are high, 3.2 nanograms per deciliter. Diagnosis of grave disease was made. Which is the most appropriate initial option for this patient? So if you are thinking about methimazole, you are right, because we already discussed that there are two options. We have two options, methimazole and propylthiouracil, but methimazole is preferred over propylthiouracil because of safety. Propylthiouracil has severe hepatotoxicity associated with it, so we will consider methimazole. So the patient is quite old, 84 years old woman. It's less likely that the patient is pregnant, but you should take good history from the patient as well. So for example, if we modify this case, like the patient is, for example, 36 years old woman, she is complaining of feeling anxious and what, then it's definitely important to take history from the patient, whether she is pregnant or not, whether it's the first trimester of pregnancy or not, because in first trimester of pregnancy, the safety of methimazole is not there. We have to consider propylthiouracil in the first trimester of pregnancy. So let's see another case. This is also related to the concepts we already discussed. 68 years old woman with a history of angina and hypertension. So there is a history of cardiovascular disease. This is very important, and was recently received a diagnosis of Graves' disease. She experiences fatigue, heat tolerance, sweating, and tachycardia. Typical symptoms of hyperthyroidism, initiation of which regimen is likely to reduce her symptoms. We are not talking about reducing the levels of hormone. We are talking about reduction of symptoms. So these questions, they can trick you. So you should focus on the STEM, whether they are asking about the initial treatments or whether they are asking symptomatic treatments. So we will wait. And the answer is, if you are thinking about propranolol, you are right, because for symptomatic treatment, for reducing the symptoms of tachycardia, for sweating and heat tolerance, propranolol is an option. And the patient is old. The patient has a history of cardiovascular disease. So beta blocker is recommended in this patient. So this is the last case. We have concluded hyperthyroidism, treatment of hyperthyroidism. Let's see the treatment of hypothyroidism now. So in hypothyroidism, the treatment of choice is levothyroxine, which is synthetic T4. This is a drug of choice because it is chemically stable, it is inexpensive. The other option is liothyronine, but that is very expensive. So levothyroxine is a drug of choice. It is active when given orally. It is free of antigenicity and it has uniform potency, because if we use desiccated thyroid gland that is full of antigens and it has antigenicity associated with it, so that's why due to these factors, levothyroxine or synthetic T4 is the drug of choice. Average adult maintenance dose is 125 microgram per day. I am not emphasizing on most of the doses, but this one is important because you have to adjust the dose based on the circumstances of the patients. For example, if the patient is having a long-standing disease and the patient is old, you have to reduce the dose to 50 microgram daily. And you can taper the dose, you can increase the dose after a month if required. But for the starting dose, start low at 50 microgram per day. And if the patient is older and the patient is also having a cardiac disease, for example, hypertension or angina, or he has having an MI before, then you have to reduce dose even further. So you have to start with 25 microgram per day. So the same concept applies because you are administering T4. T4 could increase the risk of angina or MI in the patient. So you have to reduce the dose in such types of patients. So you can see the ADR profile. You are treating the patient with for hypothyroidism, but the drug could cause hyperthyroidism. The drug could cause angina. The drug could cause MI and bone fractures, increase the risk of bone fractures in patients. So you have to be very careful with the dose of levothyroxine in older patients and in patients who have known cardiac disease. So here comes the second case, 63 years old woman. She has Hashimoto disease, which is the most common hypothyroid disorder. You can see the TSH is raised and T4 is low. Complaints of dry skin and being run down or being lethargic. What is the best drug for initial treatment? So you can see that levothyroxine, liothyronine, desiccated thyroid, all of these could be used, but one of them is a treatment of choice. Methimazole, that is not a treatment for Hashimoto disease, that is a treatment for Graves' disease, which we have discussed earlier. So option D is absolutely out of context. A, B, and C. If you are thinking about levothyroxine, then you are right, because levothyroxine is the drug of choice. It is preferred over liothyronine because of certain factors we have already discussed. This is another case related to very important concept. Patient recently initiated on thyroid replacement therapy to treat hypothyroidism. When would be the best time to recommend checking thyroid lab studies to assess maximum effects of this therapy? So you have to adjust the dose, but for how long you should wait for checking the thyroid lab studies, because we already discussed that building hormone levels or depleting hormone levels takes some time, and it takes at least a month. So you should check thyroid hormone levels after at least 4 to 6 weeks, and you should adjust the dose accordingly. 60 years old patient complaining of fatigue, gained 3 to 4 kg in weight and suffers from depressed mood. T4 reduced, TSH mildly elevated. So definitely we didn't talk about the gender, but the patient is suffering from hypothyroid disorder. Which of the following is an appropriate treatment? What do you think? So levothyroxine is the treatment of choice, but what dose should we administer in this patient? Should we consider 50 microgram daily or 100 microgram daily, and why? So this is an important point. So the patient is old, 60 years of age. So we should consider low dose of levothyroxine, which is 50 microgram per day. So this is the end of thyroid disorders. We will talk about Cushing disease now. We will not go into further detail of other adrenal gland disorders. Adrenal gland, the disorders of adrenal gland could be due to the hyperfunction of adrenal gland or hypofunction of adrenal gland. And Cushing syndrome is actually the overproduction of cortisol from the adrenal gland or hyperfunction of adrenal gland. And this cortisol overproduction could be ACTH or adrenocorticotropic hormone dependent or adrenocorticotropic hormone independent. So what does it mean? It means that there could be a tumor in the pituitary which is secreting a lot of ACTH, and if ACTH is secreting in large quantities, it would definitely affect adrenal gland, and the adrenal gland would have increased levels of cortisol. So such type of disease would be ACTH dependent because ACTH levels are increased, and if if ACTH levels are not influencing the adrenal gland and adrenal gland is itself secreting a lot of cortisol, there is not a problem in pituitary, but the problem lies in the adrenal gland. So then that disease would be called ACTH independent. So we will mainly talk about ACTH dependent disease, which is also called Cushing's disease. So I think you got the point here that the problem could be in the pituitary and the problem could be in the adrenal gland. If the problem is in the pituitary, for example, an adenoma of the pituitary, and pituitary is releasing a lot of ACTH, that would affect adrenal gland, and adrenal gland would release a lot of cortisol. This is called ACTH dependent disease. And if the problem lies in the adrenal gland itself, and adrenal gland is creating a lot of cortisol, and that would be an ACTH independent disease. So in Cushing disease, the presentation of the patient is with central obesity or facial rounding, and the patient would have peripheral obesity, fat accumulation in the periphery. There would be myopathies. There are increased risk of osteoporosis, back pain, and fractures. The patient could have glucose intolerance and diabetes, as well as hypertension. So in such patients, the treatment goal is to limit morbidity and mortality, return the patient to a normal functional state by removing the source of hypercortisolism and minimizing pituitary or adrenal deficiencies. So the treatment of choice in Cushing's disease is surgical resection of offending tumor. So the tumor is, for example, if the tumor is in the pituitary and that is releasing a lot of ACTH, then you have to remove the tumor by surgical resection, and that is the treatment of choice. Without removing the tumor, ACTH levels would not be controlled, and if ACTH levels are not under the control, adrenal gland would release a lot of cortisol. Pharmacotherapy is there, but that is reserved for patients who are not surgical candidates. I mean, the surgery cannot be performed in patients, or it can be used pre-operatively in patients to reduce or to control the symptoms. And it could be used as an adjunctive therapy in post-operative patients if the surgery is not successful to reduce the levels of cortisol. So we have different types of treatments for Cushing disease. Some treatments, some medicines, some therapies, they block the production of cortisol, and some reduce the levels of ACTH from the pituitary gland. For example, this drug approved in 2020, osilodrostat. If you have previous workbooks from 2019 or 2018, this drug would not be present in that. This was approved in, I think, in May of 2020 in USA, and it is included in the workbooks in 2021 course. So this one is important. So it blocks the production of cortisol. It blocks the enzyme responsible for the production of cortisol in the adrenal gland. It has some adverse effects associated with it, and the most important one is QT prolongation. So it is important to check baseline EKG after initiating the treatment. We have another drug, pasilotyde, which is a somatostatin analog. It blocks the secretion of ACTH from the pituitary. So it is not affecting the production of cortisol, but it is affecting the secretion of ACTH from the pituitary. So definitely if ACTH secretion is reducing, cortisol levels would reduce from the adrenal gland. It is approved for treatment of adults with Cushing disease for whom pituitary surgery is not an option. So we cannot remove the adenoma or the tumor in the pituitary, then we can use pasilotyde, which is a somatostatin analog. There are many adverse effects associated with it: nausea, diarrhea, cholestasis, increased hepatic transaminase. These are important because you have to take baseline LFTs, you have to take baseline HbA1c levels, you have to take baseline EKG before starting the pasilotyde, because it can cause increase hepatic transaminase levels. It can cause hyperglycemia, and it can cause QT interval prolongation. So it's important to consider baseline values. There are some other drugs, for example, ketoconazole, etomidate, and metotane. And these drugs were they could be considered in Cushing disease. And these drugs they affect the synthesis of steroid in the adrenal gland. They have nothing to do with the secretion of ACTH from the pituitary gland. I would like to focus mainly on mifepristone because this is very important. As you already saw, that patients who has increased levels of cortisol, they are more prone to uh, develop diabetes. So in such patients who have diabetes and Cushing disease, mifepristone comes handy because it is a glucocorticoid receptor blocking agent, and it is very useful in patients who have type 2 diabetes or glucose intolerance. So with this slide, we conclude the Cushing disease, and we will now mainly focus on diabetes mellitus. So you already know the classification and pathophysiology and diabetes mellitus. So type 1 diabetes mellitus, 5 to 10% of the cases are of type 1 diabetes, and it usually results from autoimmune destruction of pancreatic beta cells, and it leads to absolute deficiency of insulin. So that's why previously it was called insulin dependent diabetes mellitus, type 1 diabetes, because there is absolute deficiency of insulin and you have to administer insulin in such patients. Type 2 diabetes mellitus is more common in 90 to 95% of the cases, and there are multiple defects which are characteristic of type 2 diabetes. We will not go into detail. There are other subtypes. There are other types of diabetes as well. For example, gestational diabetes, maturity onset diabetes of the young, and medications could also can also cause glucose intolerance. But we will mainly focus on type 1 diabetes and type 2 diabetes. We will not go into other types of diabetes. So let's talk about the diagnostic criteria. The criteria for diagnosis of diabetes mellitus include any one of the following. So A1C levels, they are more than 6.5%. Fasting glucose is more than 126 mg per deciliter, and oral glucose tolerance test is more than 200 mg per deciliter. Random plasma glucose is more than 200 mg per deciliter with classic symptoms of hyperglycemia or hyperglycemic crisis. So if you have to make a diagnosis of diabetes from the criteria from 1 to 3, there should be at least 2 abnormal tests. So for example, a patient came with an A1C of 7.5 or 8 and fasting plasma glucose of 150 milligram per deciliter, then there are 2 criteria of diagnosis. 2 criteria of diagnosis are met, and we can make a diagnosis of diabetes. Only one value of A1C or fasting plasma glucose or oral glucose tolerant test or random plasma glucose, we cannot make the diagnosis of diabetes. There should be at least 2 abnormal test results from the same sample or into separate test samples. So this concept was tested in a question where they presented a patient and told that A1C levels were checked, but there were no reading for fasting plasma glucose or random plasma glucose or oral glucose tolerance test. So you have to consider another value, another abnormal value. So the diagnosis of pre-diabetes is also based on fasting plasma glucose, impaired glucose tolerance after oral glucose, and A1C levels, but the values are slightly lower. So for example, if the fasting plasma glucose is 100 to 125 mg per deciliter, then it is a diagnostic criteria for high risk population of pre-diabetes. If the impaired glucose tolerance test gives a value of 140 to 199 milligram per deciliter, or A1C levels are between 5.7 to 6.4%, then the patient is from high risk population, and you should screen such patients for type 2 diabetes annually. So the goals of treatment: primary goal is to prevent or delay progression of long-term microvascular and macrovascular complications. So this is very important. Due to this fact, we are not only using medicines which are reducing levels of glucose, but we are also using medicines in diabetic patients, for example, which reduces the levels of cholesterol, or for example, antiplatelet medicines, or medicines to control hypertension, because the primary goal in the treatment of diabetes is not only to normalize glucose levels, but to prevent and delay the progression of long-term complications. Additional goals are to alleviate the symptoms of hyperglycemia, minimize hypoglycemia and other adverse effects, minimize treatment burden, and maintain the quality of life. So this chart is very important because you should be very clear about the glycemic targets in diabetic patients. So if you are treating a patient with diabetes, what should you aim for? So you should aim for an A1C level of less than 7 or less than 6.5%, as recommended by American Association of Clinical Endocrinologists. You should aim for fasting plasma glucose of 80 to 130 mg per deciliter and postprandial glucose of less than 180 mg per deciliter. The criterion are slightly different between American Diabetes Association and American Association of Clinical Endocrinologists, but either one of them would suffice for you if you memorize them. So glycemic targets should be individualized. This is very important. ये जो values हैं, ये पत्थर पे लकीर नहीं है. You have to take the patient very seriously at an individual level. You have to individualize the treatment, and I will bring you a case for individualization of therapy in certain types of patients. These criteria could be more stringent or less stringent depending on the situation of the patient. So you should evaluate for these parameters every 3 months if the parameters are controlled. If the parameters are uncontrolled, and if the goals are not, if the goals are controlled, you can delay it to up to 6 months. So this is a patient, 96-year patient, very old patient. He's diabetic and hypertensive with A1C of 7.5, taking metformin, atorvastatin, lisinopril. What adjustment does the patient need? So this is about individualization of therapy based on the needs of the patient. So if we look at this criteria, A1C levels should be less than 7. And here the patient has A1C levels of 7.5. But if the patient is stable on 7.5 with the current medication, we should not add anything. So this is about individualization of therapy in such type of patients who are comorbid and very old. So A1C level जो है of 7, वो पत्थर पे लकीर नहीं है. You can make them less stringent for this patient who is 96 years of age. So treatment, what would be the treatment? For the patients of type 1 diabetes, all patients with type 1 diabetes, they required insulin. So that's why previously it was called insulin dependent. Regimens are designed to provide insulin in a manner that mimics normal physiological insulin secretion. So normally insulin levels, there are 2 types of insulin levels in the body physiologically. One is basal insulin level. So a low level of insulin secretion happens in the body physiologically over a long period of time. And there are postprandial insulin bursts secretions, which happens after you take the meal. So you should make a regimen You should design a regimen which mimics this normal physiological insulin secretion. So that's why we use basal bolus regimens, in which we use a long-acting insulin as a basal insulin, and short-acting insulin as bolus insulins. So you can see in this graph that physiologically what happens, that there is some basal level of insulin and there are some bursts of insulin after you take meals. So you should mimic this one. So you can mimic these basal levels by long acting insulins, and you can mimic these postprandial insulin burst by short acting insulins. So this regimen is the most common one, and this is called basal bolus insulin regimen. So you have one injection of long-lasting insulin and 3 injections of rapid-acting after each meal. So after breakfast, after lunch, after supper, and at bedtime, you are taking long-lasting insulin, which will mimic basal insulin levels. So how much insulin you should start with? 0.4 to 1 units per kg per day, and you should divide it as 50% as basal insulin and 50% as perindial insulin. And you should adjust the dose based on the self-monitoring of blood glucose data. So the patient should monitor blood glucose levels, and you should adjust the doses based on that monitoring data. But for as a starting point, 0.4 to 1 units per kg per day, and dividing it into 50% basal and 50% perindial is a good starting point. So for example, if a patient is of 80 kg and he requires 0.5 units per kg per day, so you can see that 80 multiply 0.5, that would be 40 units. So he requires 40 units per day. You have to divide 50% basal and 50% perindial. So 20 units are of basal insulin and 20 units of perindial insulin. And these 20 units should be divided into 3 parts if he is taking 3 meals in a day. So that would be approximately 7 units of rapid acting insulin before each meal, and 20 units of long lasting insulin at bedtime. So this is the usual starting regimen for the patients of type 1 diabetes. So you should adjust the dose of insulin ideally based on the self-monitoring of blood glucose data. So let's start with the treatment of type 2 diabetes. And in type 2 diabetes, metformin is at the cornerstone of therapy, and all patients, they take metformin if no contraindication is present, and additional therapies could be added over metformin. So for example, if the patient of type 2 diabetes has A1C level that is very close to the goal. So the goal is, for example, 7, and the patient is having an A1C of less than 7.5. So in this in such type of patient, it is very easier to control A1C level. So you only use metformin as a first line therapy. Lifestyle modifications alone could be beneficial only if the patient is motivated, and a lot of patients are not motivated at all for lifestyle modifications, and they require a pill, which is in this case is metformin. If the initial A1C level is more than 1.5% of target, then metformin alone would not be of benefit. You have to add another agent. So you have to consider 2 medications, metformin plus a second agent. We will talk which agent you can add. And if the A1C level is very high, if it is more than 10% of the target A1C, and there are symptoms of hyperglycemia or evidence of catabolism, then you should consider early introduction of basal insulin. So you should add insulin in the regimen because this patient is less likely to benefit from other medications alone. So you have to add basal insulin in such patients. So keep in mind this thing, that insulin is not only used in type 1 diabetes, it is also used in patients of type 2 diabetes who have very high A1C levels, or who have symptoms of hyperglycemia or evidence of catabolism in the body. So which agents could we add with more metformin? So if A1C is above individualized target and there is no risk of atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease, then you have to look what are the needs of the patient. So for example, if there is a compelling need to minimize hypoglycemia, you want an additional agent, but you want an agent which causes less of hypoglycemia, then these are your treatments of choice. You can add dipeptidase 4 inhibitor, glucagon-like peptide 1 receptor agonist, sodium glucose transporter 2 inhibitors, or thiazolidinediones. So you can add any one of them over metformin, because all of these agents they have less adverse effects of hypoglycemia. If you want the patient, if you want to minimize the weight in patient, and for example, the patient is already overweight and you want to promote weight loss, then the treatment of choice in addition to metformin are GLP-1 receptor agonist or sodium glucose transporter 2 inhibitors, because these agents, they are more likely to reduce the weight of the patient. If you want a weight neutral medication, then DPP-4 inhibitor is a weight neutral. But avoid sulfonylureas, insulin, and thiazolidinediones, because these medicines, these therapies, they increase the weight of the patient. So you should not add this one. If the cost is a major issue, then sulfonylureas and thiazolidinediones are treatment of choices because they are very cheap. So you have to individualize the therapy depending on the patient needs, whether the patient is obese, whether the patient has chances of hypoglycemia, or cost is a major issue for the patient. But if the patient has comorbidities as well, then you have to adjust the options a little bit. For example, if the patient has established or atherosclerotic cardiovascular disease with diabetes, so he is diabetic, but he has an established atherosclerotic cardiovascular disease, then the treatment of choices are these ones. And if the patient is of diabetes and heart failure, then you should prefer sodium glucose transporter 2 inhibitors, because they have proven benefits in heart failure progression. If the patient is diabetic and with chronic kidney disease, then you should consider either sodium glucose 2 receptor sodium glucose transporter inhibitors or GLP-1 receptor agonist, for example, liraglutide. So this case belongs to diabetes. So 66 years old man, type 2 diabetes, A1C is 7.7%. So obviously more than the target. He has altered his diet, and he states that he has been exercising regularly for months now. He's taking metformin, 1000 mg twice daily. Which would be the best choice to help optimize his glycemic control? Should we add an agent over metformin, or we should replace metformin with some other agent? This is very important concept in the treatment of diabetes. So we already discussed that we should add an agent over metformin after giving maximum dose of metformin. So 1000 mg twice daily is the maximum. So you should add another agent. So if you are thinking that option D, addition of sitagliptin over metformin is the correct answer, then you are right. Another case, 55-year-old patient with type 2 diabetes for 6 months, taking metformin, 1000 mg twice daily since diagnosis, A1C quite high, fasting blood glucose are at goal. His after meal blood glucose averages 210 to 230 mg per deciliter. That's high. He's worried about his weight and doesn't want any medications that may increase it, which is the most appropriate option. So you have to individualize the therapy. You have to add something over metformin, but you have to see which medication is more likely to reduce the weight of this patient because he is worried about his weight. So liraglutide, that is the option of choice here because it also reduces the weight of the patients. You can add 3 therapies if the A1C target is not achieved after 3 months of dual therapy. So you can add 3 agents as well. And if the patient did not tolerate the selected drugs, you can add a drug from some other class and you can reduce the doses. Adding insulin. So if the patient, if the A1C levels of patient are more than 10% of the target or the patient is symptomatic, then you have to add insulin. Otherwise, GLP-1 receptor antagonists, they are preferred over basal insulin. Basal insulin is started at low dose, for example, 10 units once daily, or 0.1 to 0.2 units per kg per day, and titrated slowly over time to target fasting plasma glucose range of 80 to 130 mg per deciliter. If by basal insulin you are not able to control the blood glucose levels, then you should consider postprandial insulin levels. And if the postprandial glucose levels are raised, obviously you have to use rapid acting insulins before every meal. So as you remember, the primary goal of treatment in diabetes is to prevent long-term complications. And to control long-term complications, it's important to manage the blood pressure and lipid profile of the patient. So for BP management in diabetic patients, the goal is 140 by 90 and more stringent BP recommendations if existing cardiovascular disease. For example, if the patient is having a cardiovascular disease with diabetes, his blood pressure should be 130 by 80, not 140 by 90. So the levels are more stringent for patients if the patient is having existing cardiovascular disease. If the patient is nephropathic, ACE inhibitors and angiotensin receptor blockers are preferred for the management of blood pressure in such patients. So we are not talking about anti-diabetic medicines. We are talking about antihypertensives, but this is important to talk here because BP management is crucial for patients of diabetes. Lipid management is done by statins, and you will have a thorough presentation on lipid management in hypertension, I think. So you will see that you have to use either high intensity statins or moderate intensity statins depending on the risk of atherosclerotic cardiovascular disease in patients. So if the risk is high, then you have to use high intensity statins. But if the risk is low, then you have to use moderate intensity statins in patients with diabetes, and you have to reduce the levels of cholesterol and other triglycerides. Sometimes antiplatelet therapy is also added in the treatment regimen in all patients who have atherosclerotic cardiovascular disease. So you have to add antiplatelet therapy as well. These are not related to the anti-diabetic therapies, but they are important in anti-diabetic management. So this is another case, 56-year-old man with recent type 2 diabetes, receiving metformin twice daily, has no other chronic disease or history of cardiovascular disease, BP 148/78, pulse 74 beats per minute, A1C 6.9. If added, which agent has the most potential to reduce both macro and microvascular outcomes? So you can see the blood pressure, 148/78. The blood pressure is high. So which agent could reduce the macro and microvascular outcomes in this patient? What about A1C? A1C is near the range. So you could add an ACE inhibitor in such patients. So the option B is correct. So that's the last topic, obesity. And there are many different guidelines related to obesity, but none of these guidelines, they recommend one agent over another. So for example, the guidelines of American College of Cardiology and American Heart Association gave guidelines in 2013, but most of the agents, they are approved after the guidelines after 2013. So obviously, they don't include those therapeutic agents which have been approved after the guideline. Endocrine Society has a guideline which was published in 2015. They have not recommended of any agent over other. They have just given a good overview of all the agents which are available. American Association of Clinical Endocrinology and American College of Endocrinology, they have guidelines published in 2016. Again, there are no recommendation of one agent over another, but there is a comprehensive review of treatment options in these guidelines. If you want to look at which treatment options, pharmacological and non-pharmacological, available, you can go and look into the guidelines. So classification is based on BMI. If the BMI is above 25 and less than 30, the patient is overweight. From 30 to 34.9, there is class 1 obesity. Class 2 obesity is 35 to 39.9, and class 3 is above 40 BMI. So the cornerstone of treatment in obesity is non-pharmacological therapy. But obviously, everyone wants a pill. No one go for, I mean, very few people go for non-pharmacological therapy. Pharmacotherapy could be used in patients. This is very important. The patients who are failed to achieve or sustain weight loss with lifestyle change alone, they have a BMI of more than 30 or a BMI of 27, but at least one weight-related comorbidity like diabetes or cardiovascular disease. So in such patients, pharmacotherapy is an adjunct, it should be added. Long-term pharmacotherapy of obesity that have a role for patients who have no contraindications to approved therapy. Otherwise, if there is some contraindications, long-term pharmacotherapy is not recommended and not studied well. So all the pharmacotherapies which I'm going to tell you, they are not studied for chronic periods of times in research cohorts. So the last point is very important, and it is tested again and again in pharmacotherapy exams, that the loss of at least 5% of total body weight at 3 to 6 months is a success. So if you are using a pharmacotherapy and you are not achieving at least 5% of total body weight loss, then you should not use that therapy for longer periods of time because of the adverse effects of therapies. So this concept is tested in this question. 55 years old female, BMI is 32. Obviously, she is type 1 obese, weight 120. What is the minimal weight loss expected in 6 months? So we expect at least 5% of weight loss in 6 months. So 5% of 120 is that is 6. So 6 pounds, that's the answer for this question. So if she is having 6 pounds of weight loss in 6 months, this therapy is working for her, and you can continue the therapy. Otherwise, you should discontinue or you should consider other options. Pharmacotherapies, many pharmacotherapies are present which could be used as an adjunct therapies. For example, liraglutide, orlistat, phentermine, topiramate, naltrexone, bupropion. Lorcaserin was in the previous guidelines, but it has been approved from, it has been removed from the guidelines because it has been removed from the market due to its association with certain types of cancers. So lorcaserin is no more present in guidelines. So that concludes our presentation of today. If you have any questions or feedback, you can write to me. You can write to the forum of Giving Back to Pharmacy in Pakistan. And thank you very much. So we have some questions, I think. Let me see.